I want to start by thanking Lisa Juckett for approaching me and asking me to give this talk today, and certainly to the leadership at the Learn Network for the opportunity. It's been great fun for me thinking through these issues and how I want to talk with you today. Special shout out to Marguerite and Derry for their organizational and technical support and making this all possible. So I wanted to start out with the obligatory disclosures, which are on the left for you today, but really talk for a second about what I think are the important disclosures that I have that are on the right of this slide today. So I am an occupational therapist, and I practiced for years before returning to pursue my PhD. I was frustrated with what I perceived as a lack of evidence for practice in our field and a lack of focus on contextual issues in particular. So my program of research is focused on how the environment can support function and participation of people with disabilities. The other thing I should admit is that I really like hanging out with older adults and my community agency friends, and so I integrated them into my research program. And finally, the most important thing for you to know is I am not a D&I scientist, but I get to work with really cool, talented, and generous D&I scientists at WashU, and so they've influenced quite a bit of what I've thought about today. So we all stand on the shoulders of giants, and two that really shaped what I'm going to talk about today are important to mention. The first is so you should know that I'm an environment and behavior scientist. So I was greatly influenced by Kurt Lewin, the psychologist who spent his career promoting action research and tried to convince psychologists and the rest of us that to truly understand human behavior, we should observe it in the real world and not in a sterile clinical environment. So you will see his influence in some of these slides. The other person that I'm so grateful to is my co-mentor for my K Award, Ross Brownson. Ross really helped me as I was trying to become a clinical trialist early in my career. I was working on improving the rigor of my research, and Ross kept asking me really important questions that helped me find my environmental pragmatist roots as I developed as a scientist. So my plan for today is that I'll give you a little content, a kind of an overview of some of my work and talk about fall prevention. And then I'll share with you how I use implementation science in my work, which is a little different. So I'm calling it, for the purposes of today's talk, designing for implementation. So I'll kind of have you explore this concept with me in a recently completed fall prevention trial called HARP, or Home Hazard Removal Program. And then we'll wrap up, and I'll be really interested in hearing your ideas about what I propose and how we've done stuff to date. So first, let me talk about fall prevention. I take any opportunity I can when I talk with healthcare professionals to share this information, because it was startling to me when I first learned these statistics, even though I was a healthcare provider. So first, every second of every day, an older adult falls. And about 25 to 33% of community dwelling people over the age of 65 years of age fall every year. The rate of falls continues to increase with each year of life. So the older you are, the more likely you are to fall. About 10 to 20% of falls result in some type of injury. Falls are the leading cause of hip fracture, the leading cause of traumatic brain injury, the leading cause of injury death in the United States. About 3 older adults die every hour from a fall. Every 13 seconds, we treat an older adult in the emergency department. And falls are more common than stroke and often more serious in their functional consequences. Fall injuries in older adults are a significant source of morbidity and mortality and are an independent predictor of admission to nursing homes. Fear of falling and loss of confidence can result, including self-restricting activity. This can impact strength and balance, contributing to frailty. It's this downward spiral where a person that doesn't have physical reserves reduces their activity, and the bad things keep happening. So falls are serious and significant. Epidemiological studies have identified a number of risk factors for falling. It is estimated that about 60% of falls have more than one or multiple causal factors. And about a third of falls are attributed to environmental causes alone. So extrinsic or environmental fall-related risks include things like slippery or uneven surfaces, clutter, poor lighting, poor footwear, step hazards, unsafe railings, loose mats, Intrinsic factors that are unique to each individual are another set of fall risk factors. Some of these are modifiable and some are not. They include increasing age, previous falls, walking aids or assistive device use, difficulty with activities of daily living, slow gait speed, poor balance, dizziness, fear of falling, urgent incontinence, comorbidities, vision impairments, chronic diseases such as Parkinson's, depression and dementia, a history of stroke, polypharmacy, foot problems. These factors can modify the way a person negotiates their physical environment. And they often will interact with behaviors, and those three will interact together to result in an increased likelihood of fall. And you can see here in this slide, this older person decided to climb up 2 step stools to reach an item she stored above her refrigerator. So she has probably some limitations in her, her functional abilities. She's probably at risk for a hip fracture if she falls. The environment doesn't really support her trying to do her daily activities of cooking, and this all taken together can lead to a high risk of falling. So half of all falls occur in the home, in all rooms of the house. And as I said, about a third are related just to environmental hazards. So there's a really strong justification for targeting the home as a potential area for fall prevention. But yet in the US, 9 out of 10 homes don't have any types of supports or modifications that would support aging in place safely. But every year in the AARP annual survey, older adults tell us they plan to stay in their homes and age in place. So the home is a great potential target for intervention. So home hazard removal reduction is the process of providing assessment, reducing hazards in the home, and really raising awareness of fall risks in a person's environment, and kind of problem solving all of the hazard management strategies to reduce fall risks. So the question is, does it work to reduce falls? There is actually strong evidence, most of it from Europe and Australia, that reducing hazards in the home can reduce the risk of falls by about 40% for older adults who are high risk fallers. Home modifications are recommended by the CDC, and they were reviewed as a positive potential intervention that are cost effective in the Cochrane review, but no studies were conducted to date at this time in the US. And the US Preventative Health Task Force determined there was lack of evidence about home modifications in the US. So that gave us this inclination that we needed to do something about it and study home modifications. So does it work? I'm going to say yes-ish, because even though there was evidence, it still wasn't accepted in the US as an evidence-based fall prevention strategy. So I was motivated to see what we could do. So the gap from discovery to public health benefit is often discussed among D&I scientists, and is a reason to get, and D&I is a great strategy to reduce that kind of discovery to practice gap. And it's a compelling reason, but I think we've all seen this figure so many times that we might become a bit dull to its impact. So I like to think about it this way. So we have well over 200 evidence-based interventions now that we've reviewed, and they're in the Cochrane review, and we know they can reduce falls by 30 to 40%. They include exercise interventions and self-management strategies and education interventions among the home hazard removal programs. But the fall death rate in our society continues to rise. In this chart, we see the increase from 2007 to 2016 in the fall death rates in the US. And as we continue this trajectory, we can anticipate 7 fall deaths every hour by 2030. So the efficacy to effectiveness gap is important. And we know just because an evidence-based intervention exists, it doesn't mean it was optimally designed. And that is one of the reasons that I think we haven't translated the findings of these studies to a change in the death rate in the US. So we know that tightly designed interventions may only work in certain contexts and only by a subset of the population. So my question really is, can we better design our research earlier in the process to more quickly translate this to a population benefit? So we started the process ourselves of trying to determine how we would tackle this problem in the US, and challenges that existed here, including different housing systems compared to our the European studies that we were aware of. The types of interventions we were proposing were part of national health systems in other countries, but there's no reimbursement system in the US for many of the elements we thought were important. So for example, in the US, we pay for home care aides or staff to provide a bath to an older adult, but the cost of a bathtub bench and a handheld shower that would allow an older adult to bathe independently must be paid out of pocket. And we perceive that as a big barrier. So we started from scratch to build an intervention that we thought would fit in the context of the US health system. We began with the literature, looking back into what has been working in other places. And so we know from some of our own work and some of the work of our Australian colleagues that there are some key elements to what needs to go into a home hazard removal program. It needs to include an assessment of an individual's abilities and the actual home environment. There needs to be a plan to address and remove hazards or barriers. Somebody needs to help the older adult implement the plan. And then the older adult himself needs to understand how to use the modifications safely. So we determined these were the essential elements, and we set about to think about how we might develop an intervention in the US. So when I was working on this issue, Ross Brownson handed me two things. He handed me the current paper on hybrid designs and an early paper of his work on designing for dissemination. This question of how can we design interventions better to ensure that they have high uptake and are used in our community. This is in this image, you can see the group that we worked on to develop the different iterations of HARP a few years ago. These are therapists, trainees, and older adults that make up our lab community. We really wanted to be true to Ross's idea of involving stakeholders, integrating science with practice, and addressing disparities. We started with D4D and in preparing our intervention, but we still wanted to think about some other potential barriers to uptake. And so we're also fortunate that we have some amazing implementation scientists here at Washington University. And so this is a slide given to me by Anna Ballman and Anola Proctor, who developed this content to help us understand what are the implementation barriers and potential outcomes that we could target to improve uptake. So we knew the thing, home hazard removal, that we wanted to focus on, and we knew we wanted to reduce falls. The question is, what could we do in the middle to really improve uptake and use of this intervention? So the idea behind this is improving implementation likelihood prior to even developing the intervention. I call this the close the barn door approach, but making sure that we shut the barn door before the horse gets out, because we work a lot in environment and we've seen some crazy things that have happened if you don't plan well from the beginning. So these are a few examples in these images of things that have gone wrong that probably could have been avoided if we'd thought better about it. So that was our philosophy and approach going into the development of our intervention. So the methods that we used to identify barriers, because we couldn't find a nifty framework at this time to help us understand the barriers to effectiveness, our own negative trials, pilot studies that both worked and didn't. We interviewed lots of key stakeholders and took lots of field notes. We conducted focus groups, key informant interviews, and conducted go-along audits. We have a community advisory board and a special community advisory board that we use just for HARP of the individuals that we were targeting to deliver the intervention to. We have lots of great clinicians who gave us lots of good feedback and ideas, literature reviews, and clinical guidelines that we developed, and a lot of our own clinical experience. So I thought I would share with you some kind of glimpses into the clinical experience that I've had and give you a sense of where we were starting when we began developing this intervention. So the first image that I have here, sorry it's blurry, but these are real images from when I was practicing. This is what I would hear. The therapist sent some things home. And when I would go to the home, I would understand that the things were piled up in the living room and not used because A, they didn't fit, or B, the person didn't understand how to integrate them into their community. And so I knew that was something we wanted to avoid in our intervention. I've heard my son installed everything for me, and I've often wondered if the son really did intend to build a hurdle over the bathtub that he wanted his mother to jump into in order to safely take a shower. So this was an example of making sure that things that did exist were installed in the correct way. People would tell me, I live in senior living, I have an accessible apartment, and when I would arrive, I would find things like on the right side of this figure, you can see the yellow arrows pointing to a tub from Target, a Rubbermaid tub that was turned upside down to serve as a tub bench. So accessible apartments don't necessarily translate into safe environments free of hazards. This one, when I asked where the medications were, so we could examine how medications were being taken, was told it's by the Texas toast. The big Texas toast is on the right side. I often felt like I was playing a game of find the object in the hidden picture. When I would find things like this, I will let you know that there are lots of dog medications from the 1970s on this table, as well as the current medications that the person needs to take. So these things older adults put in place themselves to help manage their daily activities can sometimes put them at risk. But one of the big inspirations for me was this participant, Jane Bergen. We met Jane. I share her name because she was in a newspaper article. She agreed to share her story. Jane had an amputation and received occupational therapy after her amputation to help her be independent at home. And we met her about 6 months after she had her OT because she'd fallen while she was trying to get dressed in the morning. And when we asked why she fell, she showed us where her original closet had been. And you can see that in the picture next to Jane. She would actually not use this closet because she was not able to get into the closet using a wheelchair. So she would put on her leg, which she preferred to do after she was dressed, but she was not able to do, and walk naked through her house or hop through her house, depending on the day, to get to the front bedroom where there was a wider closet where she could put on her clothes. And that was how she fell, was hopping through the living room to try to get dressed in the morning. And so you can see on the far right, there was a door that had been removed. So we knew the therapist could have removed the door in her bedroom closet because she knew how to do that, but she removed the door in the actual bathroom that was attached to Jane's dining room. So Jane was no longer able to have guests over for dinner because she no longer had a door on her dining room. So some of the modifications that we made for Jane that we wished that the original OT had done is removing the door in her closet so she could get in and have a walk-in closet, and not removing the door on her bathroom, but perhaps putting some offset hinges on so she could get in and out of it safely. So we wanted an intervention that was durable, that wouldn't allow this to happen. So methods that we've used to develop our strategies are things like advisory boards, key stakeholder consultation, review the literature. We took the long-term planning very seriously, and we thought about how our intervention would be used on down the road, and lots of pilot testing. So we did conduct a randomized controlled trial of the intervention we developed, HARP. It was a pragmatic trial, and it had a side-by-side implementation study where we looked at some process outcomes. So we tested the effectiveness of this intervention in an area agency on aging population among 310 older adults who were currently were receiving services from the AAA. The primary outcome was any fall for an individual. Secondary outcomes were number of falls, activity performance, fall self-efficacy, quality of life, and we did an additional cost effectiveness study so we could understand what the actual costs were in terms of the benefits related to healthcare. The intervention was a comprehensive assessment of home hazards and tailored hazard removal program delivered in the home over approximately 2 weeks with a 6-month booster session. So let's talk about not so much the trial, but really the implementation strategies that we built in and baked into this trial. So I've divided these into 4 different types of barriers, and we'll talk about the barrier, evidence-based strategy, and then potentially the implementation outcomes that we hypothesize will be impacted by the approach that we took. So this was As we talked, this wasn't a traditional service, and it wasn't a logical fit sometimes for outpatient services, which are based in a clinic, or home care, which is really an acute intervention. So we were concerned that costs were in line with potential funding agencies. So we really thought carefully about the type of service setting that we wanted to deliver our intervention in. And so particularly for the folks that we knew would need it, that had limited dollars, both from the service provider side and the older adults themselves. So we selected a national model for service delivery in the Area Agency on Aging. And so area agencies on aging are located in every state in the country. There's about 622 across the US and in Puerto Rico. They provide local services for older adults. You're probably most familiar with the home delivered meals that they deliver, but they also have Title II Older Adult Act money, which provides the opportunity for them to fund things like bathtub benches and handheld showers that older adults might need to be independent. But we do know that in order to access that Title III money, the interventions have to be evidence-based, and they have to go through a rigorous review period to ensure that they meet the criteria for evidence-based. So we actually played a long game with this, this line of research, and we wanted to make sure it would fit within NCOA guidelines for evidence-based interventions so that AAAs across the country would be able to provide this type of intervention. We also knew that the evidence that we had reviewed was based on a very wealthy white sample, kind of European-centric, and we wanted to make sure that the intervention we were developing worked for the sample of folks that are served by area agencies on aging. So we wanted to target that group as well. And working through the AAAs was a great way for us to do that. So that was why we targeted that intervention into the area agency on aging. So the next set of barriers that we wanted to address were really at the provider level. So the first thing we decided was that we needed to develop an intervention that could be delivered by any clinician, regardless of experience, with a training program that participants were likely to engage in. And we thought the first thing that was lacking in the literature was the ability to give all clinicians advanced clinical reasoning skills and tools to support their reasoning. So our goal was to get those tools into the hands of therapists in the least painful way and as efficiently as possible. We also knew that OTs need to be reimbursed or they wouldn't be enticed to practice in this area. So we wanted to make sure that the intervention felt comfortable and familiar to them. We thought this would address issues of feasibility and fidelity and uptake and sustainability for the intervention. So the first thing we developed was a clinical reasoning tool. This is published in the occupational, let me start over. So the first thing we developed was a clinical practice guide. We interviewed expert home modification delivery folks to understand how and why they make recommendations for certain clients. And we created this guideline that gives an expert skill set to a novice therapist. There are, I think, 14 items, and there's a description of the factor that a personal or an environmental factor that therapists can understand, and a principle that helps them decide how to make recommendations based on that the lived experience of each individual. So we hope we can avoid issues like Jane Bergen experienced in her home using clinical reasoning guides. The next thing we brought into the toolbox was a shared decision-making approach using clinical decision analysis form. So older adults are presented with potential interventions, and they're allowed to understand what the potential benefits and limitations of each of the interventions are, and they actually get to choose the intervention that they employ in their own home. So this permits tailoring and supports individuals' needs and makes sure that people don't have to hop through the living room while they're naked. We also provided therapists with an application of an environmental theory so they could make decisions in the field. So if there wasn't an answer in the training manual, understanding the theory and how the intervention worked was our next best way to make this a durable, reliable, feasible intervention with high fidelity. We manualized the intervention. It's a simple, easy to follow approach that's consistent with other manuals in the field, really designed to support novice therapists as well as expert therapists in delivering the intervention with high fidelity. We developed training approaches that fit within the typical continuing education format so that it was really palatable for occupational therapists. So if they needed to learn and understand how to deliver the intervention, we knew that the intervention could be delivered to them in, I think it's about 4 hours of a workshop training format. We also carefully designed the intervention to fit within normal practice patterns. So we knew the therapist could be reimbursed under Medicare as an outpatient service delivered in the home. And we designed the CPT codes for translating this to practice. We also made sure the timing of visits and the spacing of visits were consistent with outpatient practice patterns so that therapists who were interested could develop new innovative practice programs to deliver these interventions in partnership with AAAs across the country. So shifting to older adult consumer now and the barriers to implementation that we anticipated based a lot on our own experience in the home, but also from our advisory board. Our biggest hurdle was getting older adults to be aware of their fall risks and also empowered to address these risks. So falls are like disability. No one ever thinks it will happen to them, and older adults are no exception. Getting older adults to prevent something they didn't think would happen to them was a big challenge. We had been told that older adults also knew that if therapists were coming to work on fall prevention, it meant that they were going to have to pick up all of their throw rugs. So we had to overcome the stigma of being the therapist who made them pick up beloved throw rugs. So these were important things that we took with us as we figured out how to address older adults in this setting. So the participants were interested in helping. We're not likely to be able to afford the interventions. So the costs we knew would be a big deal for these folks. We also knew that we needed to engage in a group that's traditionally underrepresented in clinical research. So the first thing we did, our education and outreach program was developed and delivered mostly by our advisory board. They complained they could not endure one more fall prevention talk and told us we had to come up with something more innovative. They helped us come up with fall prevention bingo. We use it as a way to prime groups we're hoping to engage by providing education and outreach about fall risk. So just a shout out, fall prevention bingo is free and available on our website if anyone is interested in giving it a try. We also have an online version, so if you want to take it home for a family holiday, it's a great way to engage families in a fun and lively activity. So we knew that motivational enhancement was important, and we trained our therapists to use motivational interviewing. So we designed a mini motivational interviewing module that goes into our training program, and we have scripts and approaches to help older adults make decisions about participating in fall prevention activities, and particularly about the types of interventions that they're willing to accept in their home. We also we've already talked about Jane, and we learned early on that therapists can make changes that address the right environmental barriers, but it might be wrong for that particular person. And so we relied on our experience with Jane to bake in guardrails to prevent experiences like she had with a lot of these clinical tools. We needed to make sure the intervention was affordable and worked for participants served by the city agency. So we targeted a sample of folks from the Area Agency on Aging. So we have about 80% women and 55% Black participants with a high history of falling. So we targeted who we thought would benefit and who had been underrepresented in previous research about home hazard removal. So moving to the intervention elements, our approach was aimed at really cost, fidelity, and durability. We wanted to make sure it was easy for the interventions to be used as recommended. So we decided to put in place a few best practices and some novel theories and ensure that things were tailored. So let's look at those. So we went with kind of an opt-out approach. So we wanted to make sure that it was really hard to not use our intervention and really easy to make the choice to use the intervention. So we suggest that structural changes like grab bars are kind of the first line of defense versus asking someone for help to get off the toilet. We wanted to make sure that the strategies that people used were going to be there and be durable and be hard to avoid. We used evidence-based principles to develop the complex intervention to ensure that therapists would be able to deliver it and participants could participate successfully. We wanted to ensure participants received the essential and active elements in the same way, but that everything was tailored to meet their needs. So we used standardized approaches to make sure everyone got the same elements and the same dose, but that it was tailored to meet their individual guidelines using some of those tools that we developed for the therapists. And then finally, we wanted to make sure the intervention was cost effective to ensure that what we had was superior to other interventions or equal but less expensive, because we knew that for this particular group, it was going to be, cost was going to be a big factor. So we hope we turn some of those strategies into ideas and some of the outcomes into potential benefits. Let me share with you what happened with this trial, and we can talk in the discussion a little bit about what you think of what we strategized. So just to give you an update, this was actually a negative trial. There were no differences in the number of fallers. So the individuals, the time to event analysis was not significant. However, we did have a 38% reduction in the rate of falls, the number of falls that between the treatment and the control group. So we also did economic analysis, and we found that there was about $111 return on investment of HARP compared to usual care for this group. So the outcomes looked promising. But more important, I think some of these outcomes that we formatted ourselves using re-aim were, I think, really important. So we were able, of the participants we asked, and we went to the Area Agency on Aging and said, you are an older adult that has either fallen in the last year or you're worried about falling. You qualify for this service. Would you be interested in participating in our study? And 79% of participants decided to enroll in the trial, not even an intervention, but the trial. So that was really promising to us. We retained 82% of our participants. They completed the study. We talked about the 38% reduction in falls. Really exciting for me was 90% of the strategies that we recommended were implemented. So we might not have recommended picking up throw rugs. We might have taped those throw rugs down instead, but 90% of the time what the therapist recommended using those strategies that we outlined were adopted and implemented. 99% of what we hoped we would deliver was delivered using a visit-by-visit checklist that's self-reported by therapists, I should say. But when we check back in with participants at 12 months, of those 90% of strategies they adopted, 91 were still being used. So that's a pretty impressive adherence rate, but then you probably are going to remember that I told you that I screw things into the wall and make it really hard for people not to use interventions like grab bars. So we attribute our adherence rate to that approach that we used for the opt-out strategy. So there were about 150 treatment minutes per person that occurred around 2 visits, which is really consistent with what we see with outpatient Medicare billing. And most exciting was the supplies that would be that the Area Agency on Aging would be on the hook for were relatively modest. It was a $216 modification initially, with potentially a couple more dollars spent at 6 months to make sure things were going well. So it's a modest price in terms of the outcomes that we saw. So I'm gonna kind of stop here and kind of wrap up by saying, does designing for implementation, which I realize is before most people work on implementation strategies, does it work? And so we feel like we've used the technique successfully in this study, and we've used it in a few other studies. We have a transition home after stroke clinical trial that's rolling on, that's finding similar success, and another study looking at aging with long-term disability in the community, working with community partners in independent living centers, and again, similar similar results. When we design for implementation, we have better uptake, better clinical trial kind of success, and we hope that'll translate into better implementation on the other side. Will it impact implementation? The jury's still out. As I said, we hypothesized those outcomes, so we're still waiting to see. We are currently training therapists. We have a training program. Therapists are giving us good feedback. We're awaiting results from our application to the National Center on Aging to see if it would be accepted as an evidence-based intervention under Title III. We have a training video and manual that are coming out momentarily. I think it's interesting for me to think about, will this negatively impact innovation? I often wondered, would I create a different, better intervention if I didn't consider the constraints of implementation from the outset? So does this approach constrain innovation? And I've decided that home modifications aren't so disruptive and novel that we can't approach this problem using design for implementation, but maybe it's not right for all types of interventions, and I think we should be mindful and cautious of that. So those are some of the things I thought I'd toss out that we can talk about in a discussion section next, but I wanted to leave it here and make sure you all knew that I'm happy to answer other questions and to put up some potential places that you could find me if you were interested. So thanks for your time and attention today, and I'm looking forward to the discussion.